Welcome to Eye Contact. I'm Paul Rosen, and today we're going to talk to Professor John Marshall, who's one of the refractive laser pioneers, and we're going to talk about the evolution of the femtosecond laser in refractive surgery. John, welcome. It's a great pleasure to have you here today. More than a decade ago, you warned about LASIK surgery and the potential risks to the biomechanical integrity of the cornea. I just wondered how that had changed in clinical practice.
Well, the biggest problem I think we have is that there is no useful measure of true biomechanical properties in the clinic. There are two promising systems, one of which is called interferometry, where you actually generate an interferogram which gives a real-time strain map of the cornea. And then more recently we've seen Bruin scatter. But we don't have clinical data. What we do have says that any surgical intervention of the cornea does change the biomechanics, and these weaken the system. Do they weaken it sufficient to cause problems? I don't think so. Are we going to see continuing problems in later years? Again, I think the evidence now, after 20 years of surface surgery, is suggesting that we aren't going to see significant problems generating.
But what about with LASIK as opposed to surface treatment?
Well, again, we have this anomaly between LASIK and the novel technique recently of SMILE. If you cut through the fibers all the way around the cornea, as you do in a LASIK flap, then you're cutting something, let's say in a 5 diopter correction, you're cutting around 3.5 million collagen fibrils. So LASIK certainly produces some changes, but again, I think we've been very lucky. There is a huge redundancy in the way in which the cornea is designed. So my predictions that we'd see serious problems generated are fortunately wrong.
Okay. You mentioned SMILE, and I just wondered what your view was on SMILE and SMILE versus LASIK and the pros and cons.
It's, again, really quite interesting because SMILE came in on a theoretical concept. That is, if you cut out a lenticule but preserve continuity of the fibers in the strong part of the cornea, the superficial part of the cornea, it should actually be biomechanically less weakening than a LASIK incision. And although, again, we don't have a lot of detailed biomechanical evidence, the laboratory evidence would suggest that SMILE is going to be less biomechanically invasive. So I like the idea of SMILE. Would I have it? I'm not sure.
Okay, very honest opinion. Just moving on to collagen crosslinking, what's the role of that in terms of refractive surgery?
I think collagen crosslinking is terrific. When it was first introduced by Theo Zeiler, I gave a lecture which was, how would you like to age your cornea 600 years in 600 seconds? So I thought to prematurely age a system wasn't a really good idea. However, again, I was wrong, and I think the whole of crosslinking is really interesting, especially in pathological corneas like keratoconus. With modern developments of crosslinking systems and the ability to topographically apply the crosslinking energy in different zones, we've seen the potential for refractive surgery. Now, at the moment, we're probably only getting a diopter or so correction, but that's not the end of the story. I think there are now beginning to be changes in technology which should give us more. So for very low order corrections, I think crosslinking does have a future in refractive surgery.
Well, I mean, could you use it to treat an aberrated cornea where the actual treatment requirement is quite small?
Yes. I think that's where it's really going to be extremely beneficial, getting rid of coma and things like this. But again, the issue that's always fascinated me is that you and I have grown used to the inadequacies of our own optical system. Our cortex likes our aberrations, or at least is used to them. Change them, and my goodness me, You know, the number of times we've seen patients come through where they have absolutely perfect vision on any measurable system, and then the patient says, but I don't like it. You know, you think, why don't you like it? Well, it's not what I used to have.
No, I think that's very true. But also, if you can alter specific aspects of the aberrated cornea.
Absolutely.
And
cross-linking certainly has a role there, yes.
okay.
For
What
sure.
about combining cross-linking, as some do, with laser refractive surgery in the same sitting, for example?
I quite like the idea of refractive surgery using a laser is going to change the biomechanics and actually weaken the system, whereas cross-linking, 100% of cross-linked corneas are stronger. So to me, it's a very nice idea to actually compensate the refractive laser element with cross-linking. So things like LASIK extra certainly appeal to me, and to the FDA, I hear.
So, but do you think it's better to do the cross-linking first than the laser, or the laser then the cross-linking, or to combine them as LASIK extra?
Again, from the scientific studies that we've undertaken, if you cross-link a cornea, you actually slightly change the ablation rate, so you would have to modify the algorithms. Yeah. So I think the easiest way to do this, and the quickest way to do this, is to do the laser and then cross-link before you put the flap back.
Okay. We're beginning to hear about an entirely different approach to refractive correction, and that's using the femtosecond laser to modify the surface and the optical properties of an intraocular lens implant. I just wondered if you had any further views on that, or anything that you can enlighten us with.
I think it's a very interesting idea, and I first saw this, I think, in the Lübeck laser clinic several years ago. The fact that by using two-photon phenomena, you can actually change the refractive index. And certainly in materials, that is viable, and I think it's interesting, and it's something that we will see more of in the future. I'm less happy with the potential of producing refractive index changes in biological tissue, because for the most part they've been relatively small, apart from one study in cats, and then who knows what the wound healing is going to do. Those changes are so small and so subtle that I'm pretty sure that wound healing over a period will wipe them out. But then I've been wrong lots of times.
I'm going to ask you to look into your crystal ball and say, what do you think are going to be the biggest innovations in cataract and refractive surgery over the next 10 years?
Well, I have a vested interest, but I have to say, I think personalized medicine and genetics are going to play an incredibly important role. The more we understand of the gene control mechanisms, the more we will have the potential to manipulate them. So I see a very, very big future in gene re-editing, the sort of thing that's now undertaken with CRISPR technology, and the ability to actually manipulate the controlling mechanisms. So, sorry to disappoint you as a surgeon, but as a scientist, I love the idea of changing the genes to make the system as it should be.
And we're all going to be out of work, aren't we?
No, artificial intelligence will do that.
John, I'd like to thank you for participating in this interview. It's a great pleasure to have you here. For more information on this and any related topics, please visit us at eurotimes.org.